So, Susie, thank you so much for being on the show.
Thanks so much for having me.
Can I start just by asking, like, what got you into this field? What's the passion about that you're in this work?
Yeah, so I can't believe I'm saying this, but over almost 2 decades, I've been doing this work, specifically working with men over the past decade.
Hmm.
And I started my private practice in Illinois. It was very generic at the time, welcoming all genders, but specifically women's pelvic floor therapy, which was part of mainstream curricula when you were
Yeah.
going to being a pelvic floor therapist, very gynocentric, very female centric. And so men were reaching out to me asking for help. I've got these same issues or I have similar issues and there's no one that would help me. Could you help me? And so when I started to welcome men into my practice, it was then through their stories, through their bravery and courage to say, hey, I think there's a missing gap here. Why aren't we talking about men's pelvic floor therapy in these spaces? Why aren't health professionals suggesting that you see a pelvic floor therapist? Like all
Mm.
of this can be helped. And that's what motivated me and inspired me to write my book, Pelvic Pain, the Ultimate Cock Block, Navigating pelvic pain in men, and then creating courses to educate other health professionals in the rehab spaces to feel confident and comfortable working with people who have penises. And so
Yeah.
that's really how it all started. It was the courage and the yeah, really the courage of men who sought care and asked for help. And
Yeah.
I decided to be an advocate in this space for them.
How nice to step into that space and fill that need.
It
Now,
really
we're going to be talking specifically about pelvic pain, pain with sex and pain for people with penises. But before we start to dive into that, can you talk to us a little bit about any other kinds of things that might bring somebody into physical therapy? Pelvic floor physical therapy for men,
Mhm.
besides pain, are there other things that are treatable also?
Definitely. So besides pain, we can also address urinary urgency and frequency, urinary incontinence. If there was any pelvic surgery, radiation, etc., we know that tissues of the pelvic region are going to be significantly impacted, and that includes sexual dysfunction. So that also being on the list of things that we treat is sexual dysfunction, and that could be erectile dysfunction, ejaculatory variability, and things of the like. So,
Okay, cool. So, how common is sexual pain in men? I mean, I guess 100% in your practice, but in your work, but like, how common is it for men to have pain, and how does it show up? What are the symptoms? Are there different kinds?
right. So it depends on how research is defining what sexual pain is. And so in my world, it's generally labeled as chronic pelvic pain syndrome. And chronic pelvic pain syndrome can also mean chronic prostatitis, which prostatitis historically has been the label given to men for any type of pain in this region, whether it's
Oh,
penis
okay.
pain or prostate pain. And really, we know that 95 to 97% of men who have pelvic pain have no a prostate infection. So it's not an infection that's causing pain, but there was just no language, right? There's just no language
Okay.
to describe what's going on. So that was like kind of the catch-all diagnosis that men were given, which is very unfortunate because then that's not a an accurate diagnosis for what's really going on. So over
Hmm.
the years, we have really we the medical community has been encouraged to step away from using that diagnostic term and really coining it what it is, which is chronic pelvic pain syndrome. And so that could mean pain in the penis, pain in the scrotum, pain in and around the anus. It is any type of pain that one could experience that is has no identifiable pathogenic, infectious or surgical contribution or neurological contribution to what's happening, but also so it's the physical component of it, but also it's a deeply emotionally tied experience as well, and it creates significant distress.
Hmm.
So that is the official International Association or Study of Pain definition of chronic pelvic pain syndrome. It is pain that is lasting greater than 3 to 6 months without any known cause or pathology, but causes significant emotional, mental distress related to the gynecological, urological, and sexual organ areas.
Okay. And I mean, that still seems like that covers a very broad assortment of stuff. How much of, I mean, I don't know, maybe you could give some case examples or something. Like, how much of this is showing up just like with sexual pain, or with like either erection or orgasm or something like that, versus, oh, I'm just sitting around and I'm having
Mhm.
pelvic pain?
Yeah, so it can present itself in a variety of ways, right? So it could just be isolated ejaculatory pain, which is a common thing. Actually, I just had a patient case the other day who has only pain with ejaculation during and after that can linger for a few minutes to several hours or sometimes days. Then we have pain with an erection. So there could be this persistent pain that occurs with the erection itself and subsides when the erection subsides, or can also linger. You also have pain that is not just related sexually, but can also be transferred into activities of daily living, maybe wearing underwear, rubbing or clothes or jeans or pants that rub along the genitals that feels very uncomfortable. Maybe that pain is referred into the scrotum and then maybe into the lower abdomen and also the lower back, because all of these regions are connected. It could also be pain that's anywhere in between the butt bones. So the bony parts of the butt that you sit on, we would consider that the perineum. So any pain in and around that region that is really causing distress and dysfunction in all of your daily functional activities, which includes pooping, peeing, and sex. So if any
Okay.
of those things hurt, if you're having constipation, if anal receptive sex or play is painful, having a bowel movement is painful, peeing painful, all of those things fall under this umbrella of pelvic pain.
Yeah. Okay. It's a lot, right?
It's a
So
lot.
what are some of the causes? What are the most common causes? Like, what are the kinds of things? I mean, because it seems like sometimes this must could be the sign of something really serious, right? Cancer or something like that. But what are some of the other kinds of causes for these types of pain?
Yeah, so sometimes it could be musculoskeletal in nature. So we're talking about pelvic floor muscles that are involuntarily tense or tight and not really able to have a breadth of range of motion when we're dealing with function. And when we're talking about the pelvic floor muscles, specifically for men, and I'll bring my model here that I love using 3D models, everything between the butt bones here. So just for those listeners who aren't
Yeah, I
watching
was going
this,
to say I can't describe that for the people that are.
yeah,
You're going
yeah.
to have to go to
So
YouTube and watch this episode.
right, exactly. So, so we talked about the butt bones. So everything in
Yeah.
between the butt bones, there are muscles that attach from the one corner of the butt bone up to the pubic area, wrapping around the genitals themselves, so underneath the scrotum, and then kind of this triangle. It's like a triangular urogenital. We call it urogenital diaphragm or urogenital pelvic floor muscles. And this is the first layer of pelvic floor muscles that's intimately embraces the genitals or the erectile tissue.
Hmm.
And there are nerves and vasculature that run through these tissues. So when the pelvic floor muscles are really, really, really tense and tight and involuntarily staying very tense and tight, that can cause some significant crabbiness in the pelvis, right? Like
Yeah.
think
Yeah.
about tensing your shoulders or having tension in your jaw or having
Right.
yeah, just tense like shoulder muscles. Like it just feels sore and it feels uncomfortable, and sometimes it can feel hot, stabby, sharp shooting. That can also be indicative of a nerve related issue as well. So like the nerves that run through these tissues then also become crabby because circulation is being changed, the way these muscles and this part of the body function is being changed, et cetera, et cetera. So that could be one of it. I mentioned also the nerves. So sometimes, just like any other part of the body, nerves get aggravated, and that could be
Hmm.
related to certain sexual practices where stimulation to these tissues, like to the penis or the genitals or anywhere in this region, is too fast, too hard, too soon. Okay, so it's not enough for the body to adapt to. It's not slow and low.
Hmm.
And the analogy I like to use for this is like a callus and a blister. What's the difference? Both occur due to rubbing of tissue on the skin or rubbing the skin. The only difference here is one is slow and low. So you don't really notice, it goes unnoticed, it doesn't hurt. And the other one
Yeah.
is fast and hard,
Yeah.
right? So
Yeah.
you
Yeah.
get a wound. So in certain practices like jelqing practices, and for the audience that doesn't know what that is it's a practice in mainstream out there in media where it claims to uh, offer greater length or changing the length of the penis, and that is when the penis is erect, you squeeze the base and you basically milk or shunt blood forcefully up to the glands and to the head, and that can vary as far as hold times and how often that is being done, and that can cause some significant injury or irritation to the
Hmm.
nerves that supply the penis. And what I'm showing here is my motto is the dorsal
Right.
nerve of the penis that supplies the shaft, the foreskin, and the urethra and the glands. And so when that tissue gets irritated, that's where pain can occur as well. And that can
Hmm.
happen anywhere in the pelvis. So we're talking, that's the musculoskeletal component. Pain can also linger after having an infection. So the infection is
Yeah.
cleared, whether it's an STI or STD, or whether it's a urinary tract infection, or whether it's a skin infection, or maybe even a prostate infection like prostatitis, bacterial prostatitis. Those all are cleared, but you have the immune system and the nervous system still protective and really upregulated. And so
Hmm.
that can contribute to persisting pain symptoms. You also have the gut. So we can't forget about all the organs that live here. The rectum lives right behind the bladder and the prostate. And so if we're having like irritable bowel syndrome or irritable bowel issues, constipation, repetitive stress and strain, that can also lead to pelvic floor dysfunction. And sometimes just sitting like you go out, your butt is not used to sitting on a bench for 3 4 hours. It's a lot of pressure in the nerves of that area, and they get crabby. And so now you're dealing with like again a neural musculoskeletal issue or an aggravated nerve. um, so those are just some of the breadth of potential causes, and one that I think is difficult for people to wrap their head around is the emotional components to our physiological pain systems. You know, when there may be an initial physical trigger, but there often doesn't need to be an emotional physical trigger. In fact, you can also have pain that shows up after a significant emotional or traumatic event. So that could be relational, that could be related to sexual abuse or trauma. You know, there are all sorts of emotional factors that we need to consider as far as pelvic pain and the context around pelvic pain and the biopsychosocial contributing factors.
Could you, if it comes to mind, share an example or two of that, of an emotional cause of physical pain that you've seen in your work over all these, decades?
Yeah, so one example that comes to mind is an individual that was going through a life transition with their work, in particular involving their daughter who was going to this particular school. There was also mm, lifestyle factors too that were contributing as a culmination of this event, relational distress, and all of a sudden, you had this severe pelvic abdominal pain that surfaced. It was almost
Hmm.
like a wake up call for this individual to like this there's something seriously going on. Something seriously going on. Had all the tests done, all medical tests up the wazoo, and everything was unremarkable.
Wow.
Okay. The body went into such a significant SOS, right? That all of their systems, the immune system, the nervous system, the musculoskeletal system, the hormone system, as an ecosystem, went into bodily protective mode.
Hmm.
Okay. And for whatever reason, which, that's $1 million question here.
Right,
Like,
right.
why did this happen? And someone
And
might have
why
the same.
me? Right.
And why me? Right,
Yeah.
exactly. And things that we really don't have answers for, unfortunately, from a medical scientific perspective. But it just so happened to land in the pelvis. And so understanding that from the perspective of the psychosomatic or somatic dysfunction of it's a nervous system overdrive, and we need to kind of help to create safety, and we do use manual therapy, we do use breath work and mindfulness, and most importantly we use this pain neuroscience education that's tailored to their particular experience, having them see like look at all the things that kind of like kind of accumulated over your lifetime as far as your system asking for help, and it had to get really loud for things to take a shift,
Yeah.
right? And once that person kind of understood that and felt like they were heard. So I'd like to back up to say with men in particular, it is historically been known that when they ask for help for their pelvic floor distress or pain, they are dismissed by the medical community. Okay, so there is this unfortunate negative medical encounter that they have that is not affirming and disvalidating.
I mean, I'm only sort of laughing because the same thing happens with women. It gets totally dismissed. Have a glass of wine, right? Like, get over
Totally.
yourself.
Right.
Right.
Right. Right. And
Right.
at least, they don't say that to them, but they say, hey, you know what? Just get over it.
Buck
Like
up. Yeah.
man up. Yeah, man
Yeah.
up. Like get over it. You're gonna have to live with this for the rest of your life, right? It's like, well, how dare you say something like that when you have no idea what's going on, right?
Yeah.
Like going
Yeah.
to say like, well, we never see this in men. We only see this in women. I mean, it's just like on and on and on, the bullshit that really
Right.
is around men's health. And so this person again felt alone, isolated, dismissed, doesn't know who to trust. And then so happened, a lot of men will find me because they do their own research. They are like, I need to find something. I know that there's something out there that can help me. And then finally, they reach a provider who not only allows them a space to be vulnerable, lean into that, and to share really their most intimate concerns, their distressing concerns physically, but also emotionally and sexually. I mean, no one's asking them about their sexual health, even if they came in with, like,
Right.
constipation or this
Right.
pain
Right.
problem. Who's asking them about their sex life? Like, how has this impacted your sexuality and your sexual relationship? Like, what are those? None of that is being discussed. That's not happening.
Yeah. So, what's the role for pelvic floor physical therapy with this? I mean, is it always useful no matter the source of the pelvic pain, or how would you talk about that?
That is such a good question. So I think it depends on the approach, the perspective of the approach, working in a comprehensive biopsychosocial approach. We know that any type of pain problem, right? It could be musculoskeletal. It's like you have to be the investigator to determine what parts of the bubbles are the maybe the majority or the triggering factors here. Because it could be as simple as a musculoskeletal issue, right?
Hmm.
Relax your pelvic floor muscles, let's get circulation, into these tissues, help you stretch a little bit, and you're good to go. Other times, it's very enmeshed with the psychosocial aspects of what's going on. And so a deep learning and a reframing around their pain problem has to be infused into care. I think parts of that is always infused in care, empowering the individual, helping them understand why they hurt, and then giving them opportunities to experience and embody a feeling better, feeling good, hurting less, especially within the sexual context with their sexual encounters, right? Because it only takes one time for either their genitals or their penis not to function in a way, but now you tackle on top of that pain rather than
Right. Right.
pleasure. That's just a huge mind fuck, of
Yeah.
like, wow, and
Would you
so
say the ultimate cock block, right? Like,
it's
it's
the
like, yeah.
ultimate cock block. My opinion, the ultimate cock block, because it's like, is it worth it to have is it worth it to have sex because I'm going to be in pain and excruciating? And then not only that, but the underlying assumption without the knowledge, without the pain understanding and knowledge, they're thinking that they're hurting themselves more, that they're causing more
Uh,
damage,
yeah.
right?
Yeah.
That
Yeah.
because
Because
they're
pain is typically a sign that we should stop doing what we're doing, right?
pain is a defender, not an offender. And I don't quote me on that. That's not my quote. That is Lorimer Mosley and David Butler, who are my mentors in pain neuroscience. I ride on the shoulders of giants here, so credit to them. But yes, it is a defender, not an offender. And so there are some important pain neuroscience concepts, learning at a deep learning level of reframing how we think about pain. And that's really empowering. So the knowledge piece, so as a pelvic floor physical therapist, the knowledge piece of understanding why you hurt and understanding the multiple factors that contribute to pain dialing up and pain dialing down, and that it is changeable. Like change is inevitable. And
Yeah.
I'm here to infuse that message, but also not just to talk at someone, it's to help them experience these messages as truth in their own body, in their own experience. So there's a somatic component to like mindfulness and like
Yeah.
and lessening the fear and anxiety around sensations. I also love using cognitive diffusion principles, right? So like acceptance commitment therapy type psychological framework as well into the work that I do. My whole job is to help that person feel safe and empowered to do the things that they want to do, whether it's biking, fishing, sex, pooping, peeing, doesn't matter. I'm here to say, how do we make that happen instead of don't do this, don't do
Right.
that, which is often the message, right? Well, don't ever cycle again. You have pelvic pain. Heaven forbid you get on a bike again. I
Yeah.
mean, it's just like ridiculous fear mongering messages. So I do a lot of damage control.
Right,
Yes.
right, right.
Does that help? Oh, and I should
It
say, okay, so that's that part from a I guess a clinical philosophy framework of like movement-based therapy. So what do we do in the clinic? Obviously, once we get this big picture, we're like, all right, what do we need to do to help you have this experience that you feel safe? Now, that might be movement-based therapies that are like mindfulness, stretching, kind of again, curating an experience of safety and feeding forward that message in your body. That might also look like on the table doing touch therapy. So, affective touch therapy of touch that feels pleasurable and safe, not from an erotic or arousal perspective. There are fantastic therapeutic providers that do that, surrogate partner therapists, sexological
right,
body
right.
workers, somatic sex educators. We don't have the arousal component here in pelvic therapy and I am a sexual counselor as well. So I kind of, I infuse some of those things here, but touch therapies that feel good and not painful. And that's external, so external to the genitals, including the scrotum and penis, if applicable, and then
Hmm.
showing them or their partner how to do this at home for desensitization, or I should say sensory reintegration or
Yeah,
sensory
yeah.
integration techniques. And then we can do internal work as well. So that might be very appropriate to do manual therapy to the prostate or do manual therapy internally. Again, things that it shouldn't hurt, right? If those areas hurt, have referred pain, that should not be the case. And so we want to help improve tissue tolerance to touch and also again help that person feel safe in their body with touch, with pressure, with friction. We may also talk about strategies as far as sexual activity, changing positions, using other environmental contextual cues that might infuse the message of safety, whether it's essential oil, maybe it's music that you play, maybe it's having sex in a completely different space in the room, because where you first experienced pain during sex was in this particular room in this particular position. So guess what? Your brain has all that
Right.
information, right?
Knows
To be
to
like,
expect that.
yeah, to expect that it's going to happen again and again and again, right? And so we're using those principles, right, to help again curate more data to override the old message of protect from threat, protect from threat, protect from threat. Again, so that could be movement, that can be touch therapy, that can be just an experience, right, of graded exposure principles. So I do a lot of graded exposure to activity, to touch, etc. Um, all with consent and affirming consent throughout, right? So what might be good in one session and consensual for that patient in that session, it might not be the same for the next session, right? So
Yeah.
I think that's super important, super clear to convey to the audience here is that we may have suggestions as pelvic therapists, but you do not need to do all of them. We are always collaborative and partnering with you to meet you where you're at. Right. And in my practice, not only is it pelvic floor therapy, but I also have a mental health therapist on staff. I also have a nutritionist on staff as well, because we are often dealing with complex multifactorial systems
Right.
that may be contributing to their pain experience or their dysfunction.
I'm glad you're talking about the consent and affirming it along the way, because I'm imagining audience members maybe thinking, "Holy cow, what's going to happen when I walk walk in this office? You're going to town, you're sticking fingers up my butt. Like, what's how does this start in terms of like how does an exam go? What could somebody expect in a first visit? And then maybe you could talk us through a little bit about how this progresses and how it
Hey,
could be useful. Here's your model again for those who
here's
are
my
just
model
listening.
again. And
Yeah.
I'll just point to the back. I'm in my office right now, and you can see I have two chairs there, and
Right,
that's
right.
where it all starts.
It
So
looks totally normal there, like a regular little nice seating
yeah, two
area. Right.
chairs, some pillows, some lumbar support pillows, a nice little light back there. And then the door. So strategically, there is a door next to where the patient would sit so that if, again, I'm very trauma sensitive when I'm working with people. So if they need to leave, they can leave, and it's easy to get out. And there's, windows here. I mean, there's just lots of space.
Yeah.
So we first start, my sessions are 90 to 90 minutes approximately. Sometimes that goes over just depending on the complexity of the case. But 90 minutes generally, the first 45 minutes is just to get to know that person. So, tell me why you're here. What are the distressing concerns? What are your expectations for our time together? And then we do a bladder, bowel, and sexual health screening. So I do a sexual health intake. It may not be the full version, just depending on what that person's concerns are, but I'm always asking about sex. And people have the choice to say pass
Right,
or
right.
they'll delve into more details. And then we kind of get into the body movement assessment. I'm a globalist when it comes to movement assessment. So based on what they're telling me, my clinical brain goes into, okay, here, let's try these particular movements. What does that feel like in your body? Does it provoke symptoms? Does it reduce symptoms, etc.? And then the final portion is the actual exam. But before we even get on the table, I bring out my model here. This is the mascot
Right.
that it's a genital, it's a penis model that has the muscles and the nerves and
Yeah, the
this
whole pelvis area is
yeah, the
what we're
whole
looking at here.
pelvis
Yeah.
area, yeah, the bladder, prostate, and rectum. You can actually open it to look inside, and people love that, right? Because they're like, "Oh
Yeah.
my gosh, I didn't know about all these parts and how they
Yeah.
can contribute to what's going on." And so I educate them on here's what the external and internal exam would look like. Sometimes, it's not always that I assess the genitals. It just has to be specific for that person. But I am always just checking the skin as well. I mean, looking for any unusual skin issues, moles, etc., redness, anything like that. But I do tell them, like, we will be assessing this area. First is just observational, then we'll go into palpation or touch. I use two fingers, gloved. You're on your back. I feel your right butt bone, and then I kind of feel the tone of these muscles. I have you do some contraction and relaxation just so I can assess the tone and the function and your awareness of this part of your body, and if there's any elicitation of your symptoms. What I tell people here is that your body physiologically has reflexes here. Any type of touch, non-conscious or conscious, is going to pass along messages to your spinal cord and to your brain, and that might elicit a reaction. And that could be an erection or it could be spontaneous ejaculation. And I
Okay.
tell them up front, it may or may not happen. We handle this very professionally. I will give you a moment, to compose yourself, etc., or we kind of work through it in that moment. But please don't be embarrassed or ashamed. This is a safe space. Like, that stuff can happen. Okay. So I'm very relaxed about it all. And that puts their mind at ease, of course,
Yeah.
knowing that it's still on their mind of like, I hope this doesn't happen. I hope this doesn't happen, because that's like in my experience, the number one thing that men are a little anxious or apprehensive about, especially with a female identified
Yeah,
provider.
that they're going to end up aroused. Yeah.
Yeah, or that there's going to be some misconstrual
Yes.
around the therapeutic relationship, which is, again, which is I have a therapeutic relationship agreement. They sign it before I see, here's a therapeutic container, and this is my expectation for your safety, for my safety, et cetera, et cetera.
Yeah.
Um, it's just open. You just name it,
Yeah.
right? And so yeah, we go through that whole spiel. I talk to them about the internal. I also say that's not necessary. And any part of this exam that feels triggering physically or emotionally, please let me know. We do not have to continue. There are ways to help you feel better in your body that can look very different from this particular suggestion, right? This is information, but we don't have to grit and bear it to get through it. Okay. And that's how it goes. So then they'll lay on their back, legs are up, I have a warm table, a nice weighted blanket, try to make it very calm and soothing for them, having them breathe to regulate their nervous system. I might crack a joke here and there if appropriate, like to help them feel calm, always
Yeah.
engaging. I might have them hold the model, so it's very collaborative, the
Yeah.
assessment. and any treatment. And then if we're going to do the internal exam, I ask them what position they prefer as well. So it could be supine or on their back, or it could be on their side, or it could even be on their belly or in hands
Hmm.
and knees. I mean, it's really like, what do you feel comfortable with? What part of your body feels less vulnerable to proceed with this particular exam if you're going to do that? And so helping them be, part of the decision making process, even for the exam itself. And then we do the exam gloved finger, one finger, which is usually my index finger, lubricated, again, very slowly. It's not a prostate exam like what some men might be used to is a digital rectal exam, which is like in and out, like bend over, drop, drop trowel, bend over, in and out, like the whole process. You're like, before you're done, you're like, what just happened?
Yeah, exactly.
What just happened? I feel like, no what, like, no, here we're like, I breathe with you, I help your body regulate, because we're not just palpating the prostate, we're feeling all the deep pelvic floor muscles, and it's a little longer, which can feel a little
Yeah.
intrusive, right? And so I'm regulating with their nervous system, helping them breathe, contract, relax, take a deep breath in, and then we're going into, and I never push past resistance, like if there's a lot of body physical protection going on, I will name it. If
Hmm.
we can't really work with it in that moment, I will say, okay, I'm done. Take a deep breath in, and we've got enough information to work with, right?
Right,
So
right.
that is basically the exam, and then we wrap up with explaining kind of my findings and a preliminary plan of care.
Yeah. That's great. I mean, it's really striking the efforts you've gone to make this comfortable and safe in the container and create that space, to be matched by men's bravery and vulnerability to come in and let you look
Absolutely.
around.
Absolutely. It takes years for some men. I just had a patient yesterday. I knew about you 2 years ago. I had a buddy tell me about you. I looked you up. Oh no. Like that was
Well, I
exactly
mean,
what
even
you
for me as a sex therapist, I will hear that. We looked you up years ago, and now we finally have the
said.
courage just to come talk about this stuff.
Yes.
I'm not touching or looking and it's
Yeah.
it's it's
Yep. Exactly.
incredibly, I don't even know what to call it, personal and
It
vulnerable.
it
And
it
yeah.
is. It totally is. And then when it's all done, like that patient, he said, it really wasn't so bad as I
Yeah,
thought.
right. Why did I wait so long? Yeah.
It wasn't really bad. He's like, you really made that really comfortable. Thank you, And I was like, you're so welcome. And I hate to say this, but unfortunately, it's not the experience of men who seek care for, if they see a pelvic therapist, it's not always that experience. Sometimes it is
Right.
negative, and that happens across all professions. I'm sure even in your field as a sex therapist, people have experiences with providers are like, what?
Right.
And you're like rolling your eyes, I can't believe you did that, and that are shaming, right? Maybe they did have an erection and now they're shamed, and the therapist all of a sudden was like, that's inappropriate, and calling them
Yeah.
out, and then discharging them and sending them out the door. It's like it's a really disheartening. I hate that continues to happen. Unfortunately, it does.
Yeah. Yeah. So where can people find you? Tell me, tell them your website or whatever you've got available that you might want to mention.
Yeah, so my website is drsusieg.com, drsusieg.com. I'm also on YouTube. You can find me at Dr. Susie Gronsky. And on Patreon, it's a special community that I've created for men. Believe it or not, they are all 99% men, a few handful of females there for their partners as well. So I'm on Patreon at Dr. Susie G, DRSUSIEG.
I'll have to get all of those in the show notes so so we can get those
You.
in. Well, thank
Thank
you so much.
Oh, thank you so much for having me, Jessa. I appreciate it.